Welcome to the side event for this year's COSP called Disability Aware OPCAT Monitoring, a COVID Imperative. This is a side event by Queensland Advocacy for Inclusion. My name's Matilda Alexander. I'm the CEO of QAI and welcoming you here today. Queensland Advocacy for Inclusion respectfully acknowledges the Aboriginal and Torres Strait Islander peoples on whose land we work, and recognise their role in our work in the disability community and in society. And we acknowledge the First Nations people around the world here today. Queensland Advocacy for Inclusion is an independent advocacy organisation advocating for the protection and advancements of the needs, rights and lives of people with disability in Queensland, which is a state in the northeast of Australia. We're a registered charity and community legal centre. Today we've got the following speakers. Marley Hermans, a former policy and project officer with Women with Disabilities Australia and a current policy officer for First Nations Disability Network and a First Nations young person with disability. I will be speaking as the Chief Executive Officer and a human rights lawyer with Queensland Advocacy for Inclusion. I was the former principal lawyer and director with Prisoners Legal Service and course convener for prison law at Griffith University. And we also have Naraja Clay, who's a disability aware, who is one of our consultants on the Disability Aware OPCAT monitoring project and is a First Nations young person with disability. Today, we're going to firstly ground ourselves in the lived experience of people with disability in closed environments, and we'll have some words from Marley and also a contribution from Naraja in that respect. We'll then be talking about the optional protocol for the Convention Against Torture and the Convention Against Torture itself, and discussing why there is a need for a disability-aware approach to monitoring under those conventions and the intersection between the CRPD and the Convention Against Torture. The overarching theme of COSP this year is building disability-inclusive and participatory societies in the COVID context and beyond. So we're going to be talking about what did COVID-19 look like in closed environments? What was the impact on people with disability? And concluding from that, the importance of deinstitutionalisation. We'll look specifically at a report prepared by the Queensland Human Rights Commission about treatment of a woman with mental illness in prison. And we'll introduce the new resource that QAI has prepared, which is aimed to further a disability-aware approach to OPCAT monitoring. Finally, we'll look briefly at the situation and the differences for women in closed environments and what we need to be aware of there, and leave time for questions. So this is a pre-recorded interview, pre-record. So we are here, we're answering any questions, so please pop anything that you've got into the chat along the way. You don't need to wait for the end for questions, so pop into the chat. If you want to do it now, say where you're from, what your organisation is, and anything else that you think is relevant. We're really keen to meet you and make those connections through the side event today. So now I'm going to hand over to listen to some words from Marley Hermans about her lived experience.
The following is an extract from the work of Marley Hermans. Marley is unfortunately unable to be here today, but shared the following reflections on the role of hospitals during the COVID-19 pandemic. As hospitals and aged care living centres become the front lines in the struggle against COVID-19, now more than ever we must confront and interrogate the role these institutions play in our lives and how we must reshape them towards the social good we need in our communities. I am confronted by both the immensity and urgency of this task as someone who has spent the better half of my young adulthood in these spaces, caring for sick and disabled family. My mum, Julie, a Wiradjuri woman, spent the last years of her life institutionalised in hospitals, subjected to increasing violence and having her identity weaponised against her. Having witnessed the way these places controlled and ultimately ended my mum's life, I have come to understand the way in which hospitals and health professionals alike are required to perform to a strict set of politics that dispose of disabled people, poor people, and others considered not human enough. My personal experiences have reflected a narrative oppressed people the world over understand to be true. Hospitals do not exist in a social vacuum. Hospitals are not inherently benevolent, nor are we promised healing and safety inside of them. They are institutions like any other that grasp tightly to capitalist ideas about which bodies may be productive and therefore considered worthy of continued life. They are institutions that grasp tightly to eugenicist and colonial politics that would see many of us killed off. And they are institutions that stratify and limit access to care depending on capitalist paradigms of access and affordability. Since invasion, healthcare professionals in these lands have often acted as agents of control rather than as agents of care. Settler colonial states, such as Australia, have long understood the penal potential of hospitals. The brutal violence of lock hospitals, such as those established on Bernier and Dore Islands off the Western Australian coast, are not too distant from our cultural memory. Aboriginal people were removed from their homelands by police, often in chains, and subjected to medical experimentation and deplorable conditions. The workers in these institutions were not neutral agents. They served state programs of genocide and oppressive social control. Nurses, doctors, and researchers working today are not individually responsible for these long histories of medical incarceration, but they are still representatives of a profession responsible for the institutionalisation of the poor and marginalised, and the intergenerational trauma of medical abuse. They operate at the direct interface of health and well-being, and as such, every aspect of the institution must be held to the highest standards of empathy and responsibility. To accept anything less of hospitals can only lead to further tragedy. Today, this is the same institution denying disabled people dignity and withholding critical care based on assumptions concerning quality of life. It is the same institution that has been reported as rationing critical care for disabled and aged people in the midst of a global pandemic. It is not enough to improve medical care for marginalised people. We must radically reimagine our health systems. If we are all to survive this crisis and birth from it transformative and just ways of caring for one another, health professionals must work towards building relationships of solidarity and trust with oppressed communities. This demands a rethinking of how we value life and how we want our hospitals to function. It demands listening to the voices of the countless disabled, poor, and other oppressed people that have suffered in these spaces, and making space for people from our communities to become leaders in health. It demands that nurses and doctors stand with the people and not those ideologies that desire our end. Until then, our communities can and will continue to work towards a world where our healing and care is not only possible, but realised within hospitals. And those of us who have lost health, dignity, homes, or loved ones to hospitals will continue to remember and remind.
Thank you, Marley, for those powerful and important words. It's so important for us to ground our experiences and our advocacy in the lived experience of people like yourself. So it's wonderful to have someone so articulate and forthcoming in describing their experiences. The next speaker we have today is Naraja Clay, who's been working on the OPCAT resource, but she's also going to talk from the perspective of somebody with lived experience of closed environments, including during COVID times. Thanks so much for talking to us, Raja, today about your lived experience. It's an incredibly brave and powerful thing that you're doing. So speaking of power, one of the part of the definition of torture is the powerlessness of people who are in closed environments. It recognises that. Naraja, do you want to tell us a little bit about your lived experience?
So I, over my lifetime, have had different experiences of hospitals in mental health units in that particular institutional setting, and experiencing inpatient stay during COVID-19 in the first year in particular was like extremely difficult because you had no power. There were overarching COVID-19 policies and practices and legislation put in place that restricted how many personal visits you could have, the amount of like professional visits you could have. There were time limits on how long those people could visit for. There were very specific restrictions around leave from the unit. So you could only have leave if it was part of your discharge planning, and, you know, discharge planning was up to the treatment team. So you didn't really have a choice in when you were allowed to leave the unit. It was up to the treating team and for you to prove to them how well you were before they'd even consider discharge planning. So I think it actually came down to more of how compliant you were with the treatment that they were prescribing as to whether or not discharge planning was something that they talked about, and then you were allowed to have grounds leave.
So power, and it's interesting you're talking about power, because powerlessness is actually part of the definitions around torture and one of the things to watch out for. Did you feel like you would be believed if you were to report, say if you saw abuse or if you experienced abuse in that situation?
I don't think so, because specifically in Queensland, we have a locked wards directive in all of the mental health units, and that essentially makes everybody an involuntary patient. And it became, I guess, like with COVID-19 and the restrictions and then the implications of those restrictions, it essentially meant that anyone that was in one of those units was involuntary because you weren't allowed to leave. And you'd have in my personal experience, I had a treating team that when I asked to be discharged, they said, you know, sure, you can leave, but we will then bring a treatment authority against you, which is making it a legal issue, and that would take away all my choice and rights in like treatment. So I think systemically there's already a lot of like restriction, and then COVID-19 was the perfect storm for a lot more restriction without the monitoring, because they were one of the visits that were initially stopped and then brought back in a very reduced capacity.
And how did you feel that COVID impacted on you as a First Nations, as an Indigenous person?
So in particular for me, my family and community and the supports I get from them is something that is very vital to my recovery and to recovery from what I was in hospital for. And with the restrictions of only having, so the restrictions that I experienced where you could only have 2 personal visitors or professional visitors, but you could only have 2 visitors for a period of 2 hours, and they had to arrive at the same time, and one of them could like leave a bit earlier than the other, but like essentially they had to come in at the same time. And it was just a nightmare as a person in that specific environment to try and navigate. Like, I'm just trying to focus on getting well, not like how to navigate policies or practices. And so it hampered a lot of my recovery. Like, that was something that was a very big, I guess, road bump, I don't know, speed bump.
Mm-hmm.
It is, yeah.
Yeah. And was there anything that made you feel safe or would have made you feel safer in that environment?
think if monitoring had still continued on a face-to-face capacity, because, you know, I guess if it's just over phone calls, it becomes your word against their word, and more often than not, due to how these institutions have been set up, they don't believe the consumer or the participant in it. It's just they're really unwell or whatever it is, so their perspectives or point of view are not considered as important, or maybe they're not. People may assume that they're not telling the truth, or maybe they're exacerbating things, and so it just kind of creates a perfect storm for someone to like report or say that there are things happening, but due to whatever particular like COVID restrictions were in place, it just meant that monitoring bodies and disability support people and all those kind of folks that work to keep those participants and consumers safe, they weren't able to have like direct, you know, face to face with the people and see what was really going on.
Did you say there was restricted visits as well, so professional visits?
Yeah, so it was very difficult for monitoring bodies to get in to do the visits. Initially it was all phone calls and video calls, and it just doesn't work, because you have to have the privilege to be able to access a laptop or an iPad or a phone and internet to be able to speak to them, because I know some institutions don't provide that. They might provide you a landline phone number, but it's not necessarily private, so you can't exactly talk about the concerns you have without other people overhearing it. And if there's some questionable things happening, there's not a lot of ability for others to look in and kind of question that. And COVID-19 restrictions and policies just further hampered that. Yeah.
Thank you very much. Thanks. It's really important that we all stop and we all listen and we all think about the fact that we have our liberty, other people do not, and that we as disability advocates have the responsibility to look behind those closed doors and to see the most vulnerable places to abuse, and to listen to the voices of the people in there. So thank you for sharing your story. It's very brave and very courageous, and I'm sure everybody today appreciates it.
Thank you. I guess maybe just a summary note from me.
Yeah.
Closing point on that is just, I think if the community services and the community organisations were actually there and they were adequately funded and appropriately funded, all those kind of things, if I'd been able to access community, I may not have had to interact with hospitals or those institutions, and I could have received the same treatment and support that I needed in a less restrictive, more holistic setting. So
in the community,
in the community,
not in a closed environment.
Because I don't think healing happens in closed environments in any setting, and the community offers that unique opportunity of time and maybe different perspective. I don't know. Yeah,
that makes a lot of sense.
Yeah.
Thank you.
Thank you.
So the Convention Against Torture and the CRPD are both important human rights documents for people with disability in closed environments. The Convention Against Torture says that no one shall be subjected to torture or cruel, inhuman or degrading treatment or punishment. And the protocol for OPCAT, the protocol for the Convention Against Torture, establishes a system of regular visits undertaken by independent international and national bodies to places where people are deprived of their liberty in order to prevent torture and other cruel, inhuman and degrading treatment or punishment. So torture is when someone in an official position intentionally inflicts severe pain or suffering and humiliation, whether physical or mental, on someone else. And torture can never be justified. It might include physical or sexual harm, including beating or rape, or psychological harm, including prolonged solitary confinement or indefinite detention. Monitoring is important in closed environments because they are areas where control is exercised over every aspect of a person's life. A person who is otherwise a parent, worker, friend, or chess player becomes reduced to a prisoner, patient, or client. OPCAT is an effective instrument to identify and report devastating forms of violence and abuse experienced by people with disability, manifesting as torture and cruel, inhuman, and degrading treatment. And OPCAT monitoring extends beyond traditional sites of detention, such as prisons, to include disability residential institutions, forensic disability services, and mental health units, also dementia care and aged care. Anywhere where liberty is restricted. So it's about the substance, not the name. Now, innovative models of monitoring under OPCAT centre people with lived experience, and QAI advocates for the adaptation of disability-aware models of monitoring closed environments as part of the implementation of this protocol. People with disability and their representative organisations must be involved in the establishment and rollout of OPCAT monitoring. So this might be through peer monitoring models and ensuring accessible resources. So OPCAT is an important lens to view specific practices of institutional violence, including restrictive practices and solitary confinement. So we need this disability aware approach because there are specific forms of closed environments that affect people with disability, like mental health wards, forensic disability services, but there are also people with disability disproportionately represented in other closed environments like prisons, aged care, and watch houses. People with disability are particularly vulnerable to torture or cruel, inhuman, and degrading treatment in closed environments due to restrictive and other practices used in response to disability or vulnerability to COVID. And they're also due to difficulties with reporting acts of torture or cruel, inhuman, and degrading treatment. And civil society organisations are uniquely placed to see what is happening behind closed doors and to contribute expertise and oversight to monitoring the treatment of people with disability in closed environments. So during COVID-19, we saw a range of different changes in laws, changes in policies, changes in directions that impacted on the way that closed environments operated. There were comments by the World Health Organization that said that prisons, for example, could limit movement in order to prevent infection, but the impact should be mitigated. And often we saw this debate about the right to life and against all of the other rights. So people did not want to be sent to an institution as a death sentence. So they wanted to have that safety, but we need to now, at this point in the pandemic, we need to ask at what cost. So during COVID, we saw an increase in restrictive practices and solitary confinement as measures to limit the spread of infection, and professional and personal visits were reduced or curtailed. Leave of absences were cancelled, and sometimes well after the rest of society had returned to pre-pandemic freedoms. Rather than reducing the number of people in closed environments, progress stagnated as people became unable to demonstrate their reduced risk in less restrictive environments because they were not able to get leave of absence. So we saw a reduction in access to monitoring bodies to report potential violence and abuse. And even despite all of these restrictions, we saw closed environments continued to pose an unacceptable risk of infection for people with disability. So the conditions that I've listed here as being affected included the visits. So professional visits, including disability supports, lawyers, that kind of thing, as well as personal visits. We saw a drastic increase in solitary confinement, and noting that the Mandela rules for the treatment of prisoners, the UN rules, prohibit prolonged solitary confinement of over 15 days. We saw reduced access to health services, and we saw increased mental distress. We saw problems with abuse and neglect, the monitoring processes fell down. People with disabilities are often more vulnerable to COVID, so more likely to be in the closed environments, and then also more likely to have that risk exacerbated through that process. And things like hygiene and overcrowding exacerbated risks. So there was a campaign here in Queensland where people were sending bars of soap to people in prison because they had to, that was not a free item. So the kind of basics that we took for granted when you're not in a closed environment of how to stay safe from COVID were not necessarily the case for people in closed environments. Especially so whole facilities were locked down. We had instances where a whole closed environment was locked down because some of the guards, for example, or some of the workers there had tested positive, and there was a massive problem in distribution of food and medication and the basics of life. So I think that what COVID-19 taught us is the importance of deinstitutionalisation as the only viable solution. So institutions simply cannot protect the right to life without limiting these other rights. This was abundantly clear, including rights relevant under the Convention Against Torture, such as prolonged solitary confinement. And I note the Secretary-General has recommended in the Disability Inclusive Response to COVID-19 to reduce the number of people with disability in institutions and to reduce the number of people with disability in prisons. And we did see this happen. We saw over 1 million prisoners released worldwide, and Penal Reform International reported a number of different countries that reduced hundreds their populations of prisons by hundreds of thousands. We didn't see the same thing in our experience at QAI in the work that we were doing in disability institutions because of these issues with people couldn't get leave, so they couldn't prove that they were able to be released safely. So yeah, that was certainly, COVID raised a lot of questions, I think, and also raised deinstitutionalisation as the only viable solution to many of those questions. So the imperative to deinstitutionalise was heightened and continues to be so. Looking at one of the cases that was reported on here, it was an unresolved complaint under our fairly newly established Human Rights Act, where an Aboriginal woman with mental health conditions was placed in solitary confinements. And this was upon her entry to a prison. There was a general COVID policy. This wasn't something particularly targeting her. It was a broader, and it wasn't done out of malice either. It was just a broader change in response to COVID that said that personal and professional visitors were prohibited. The policy was called the Prison Isolation Policy, and it said new prisoners to the prison are to be held in solitary confinement for 14 days in a single cell. You know, that's 1 day less than the Mandela rules, mandate. But then this person was held, who was known as C in the complaint, was held for longer than 14 days due to transfer to a medical unit for treatment in that time. And then her 14 days started again. So the Human Rights Commission looked at the Mandela rules, which require access to personal visits, access to a lawyer, access to independent complaints bodies, cultural support, fresh air and exercise. And they said that the purpose of the restrictions was proper and was rationally connected to preventing the spread of COVID-19. They didn't make any findings of fact to determine if the treatment was compatible with the rights, but they did criticise the wording in the isolation policy that allowed for isolation for more than 14 days in exceptional circumstances. And the rights, they said rights shall be provided to the greatest extent possible, and said that's not the least restrictive option. The Human Rights Commissioner also criticised the lack of fresh air, echoing OPCAT monitoring bodies in New Zealand that have said the same thing. And one of the quotes from the case says, according to international experts, including the World Health Organization, certain entitlements must continue even during the pandemic. And this case resulted in 3 recommendations from the Human Rights Commissioner: mandating an end to solitary confinement after 14 days, unless there is health advice for an extension. Secondly, while in solitary confinement, ensure access to medical services, access to a lawyer, access to communication with family. And for many countries nowadays, that can be done via video calls, telephone. There's a range of different technologies. Access to monitoring and complaints bodies, and access to cultural supports. And also to amend the policy to ensure access to daily fresh air and exercise. So there's a number of other resources which might be useful if you're looking at engaging in OPCAT monitoring and going into closed environments, and the best way to do that, the way to, I guess, see into the darkest recesses, the doors that have been closed, how to make sure you're going where you're most needed. And we've listed those other resources up on here. And in particular, that last one, the Ithaca Toolkit, is a guide to monitoring human rights, including the right to health and mental health and social care institutions. So now I'll hand back to Naraja, who's been working on a new disability aware OPCAT monitoring resource for QAI, along with a team here. So Raja's going to introduce that resource and talk about how it's come to be developed. And please do jump on our website where you can download copies of the resource and use them.
QAI was funded by Legal Aid Queensland to produce a resource that will bring disability awareness to implementation of the optional protocol to the Convention Against Torture. The resource being launched today has 2 clear benefits. It will first and foremost provide essential information for the people with disability living in places of detention, their families and supports and peer monitors. The resource will provide the tools to identify violence and abuse and report this to the formal OPCAT monitoring bodies engaged in monitoring places of detention for people with disability, including in forensic and mental health settings. This resource will have a secondary benefit of providing guidance to these inspection teams to inform a disability-aware approach. By developing a resource that relates the important human rights of preventing torture, cruel, inhumane, and degrading treatment for people with a disability in detention in Queensland, we make the realisation of human rights real for the most vulnerable. After extensive planning and consultation on the development of the resources, we decided to target 5 key institutions most affecting people with disability. So disability, including residential homes and special education schools, justice settings, immigration settings, youth justice settings, and mental health and dementia settings. So we'll have a quick flick through these easy read resources now. We then produce detailed information about each of the settings, including key questions and example scenarios. So I'm just going to show what we originally started with as draft, and then we can go through. So we recognise that this information would not be accessible to many people in Australia or elsewhere. The Australian Bureau of Statistics found 44% of Australians between the age of 15 to 74 are functionally illiterate. A functionally illiterate person cannot read or write above a basic level to manage their daily living needs or employment tasks. And as you can see, this in this draft example, it's quite wordy. So QAI engaged the Centre for Intellectual Disability to translate these documents into easy English. And we'll go have a look at the resulting products. So this first one. So this is the resource for people in disability settings, including residential homes and special education schools. And this is the final draft that has been translated by the Centre for Intellectual Disabilities into easy English. So we'll just have a flick through it. Again, if you have any questions, feel free to pop them in the chat and we can talk to them. So it is a bit of a longer document, but I think part of that is to ensure that we covered everything that was that needed to be covered and explained and illustrated it in a way that was easy to understand for anybody in particular in this context, the disability setting. And this resource is for justice settings, so that is police custody, watch houses, prisons. Yeah, and so there's also another, so there'll be another resource for the youth justice specific context, but as we flick through this, you can see that it's been illustrated out to clearly highlight potential issues with the treatment that someone is having whilst they are in police custody or justice settings. So these resources will be available on the QAI website. So this resource could have been used in the example given earlier from the Queensland Human Rights Commission with the woman that was in solitary confinement for more than 14 days. So this resource could have been, as an example, could have been provided to her while she was in there, so she could have a read of it, and she could then start asking questions about it and asking to speak to an advocate or the appropriate person to discuss her concerns. So this could, it's a very tangible resource for people to be able to use. Support workers could work through it with their participant. Sure, parents could work through it with their children. It's, yeah, a resource that can be translated into many different settings. I don't know if that was what I was looking for. Yeah. So this is what the first page of the resource looks like. It's very basic, laid out very basically, and it says, this info guide talks about your rights when you are with the police or in prison. This info guide will help you know what is okay and what is not okay when the police search you, when you get arrested by the police, when police ask you questions, and when you are in prison. On the second page here, we've got contents to make it easier to navigate around the specific rights. So if a person is concerned about their rights in relation to being alone for a long time or solitary confinement, then they can go to page 10 as indicated on the contents page. If they have concerns about the conditions of the room or cell that they are in, then they can turn to page 16, and there it's able to step them through some very clear kind of guideline around what your rights are. And this is page 16, so this looks at your right to live in a good living area. So a person who is in prison, they may be reading through this and they may see that, well, actually my bathroom isn't accessible. I don't have the supports that I need to stand up and have a shower. They may realize that the room that they're in is not clean, or that they actually are supposed to or allowed to have a window, or should have a window, sorry. And then this I guess gives them like tools in the conversation to have with the people that are in charge of those settings to kind of bring around another conversation of rights and what it looks like to ensure that people's human rights are being met whilst they are in these settings. And so that's a quick overview of our resources. There will be more available for the rest of the settings in due time, but I will now hand over back to Matilda Alexander to give us some more info about it. Thank you.
So we have left this page to get more info. So you can add what's relevant to your context, bearing in mind there are different places to access information depending on whereabouts, what state or territory or what country you might be in. So we wanted to have a little focus on women before we finalised our side event today, noting that the UN General Assembly resolution has urged states to take positive measures to address structural causes of violence against women and to strengthen preventative efforts that address discriminatory practices and social norms, including with regard to women who need special attention in the development of policies to address violence, such as women in institutions or in detention. And we note that the definition of torture includes torture acts that are done for a discriminatory reason. So it's actually built into the definition there, which is relevant to women and to others who suffer discrimination. And closed environments can impact on women in particular ways. And this is reflected in United Nations documents such as the Bangkok Rules for the Treatment of Women. And we note that not all women have these characteristics and that these characteristics are not only limited to women. But generally speaking, for women in closed environments, there needs to be care taken at admission to ensure that where they are the primary caregiver, that there is a means for, they may have the child with them or they may need to contact others to arrange for care for that child. There are particular aspects around pregnancy and breastfeeding that may impact on things like the way that restraint can be used, the way that healthcare should be administered, and particular healthcare like gynecology or pregnancy care may be needed. There may be breastfeeding concerns. A woman may be breastfeeding upon admission. There may be particular needs that women have around personal hygiene and menstruation. And there may be particular needs around healthcare, including gender-sensitive healthcare and preventative healthcare. Many women in closed environments have a history of sexual assault, having been sexually assaulted in their lives, and this can impact on a variety of different practices in closed environments. So things like strip searches are additionally traumatic. Urine tests, things like that can be additionally traumatic when for somebody whose body has already been violated in that way, to have it further, those practices further replicated through state systems of control. So they're just some extra things to think about in relation to the treatment of women in closed environments, and a disability aware approach to OPCAT monitoring needs to have an intersectional approach that thinks about all of the different aspects of all the different people who may be in closed environments. To conclude, I want to end with the words from Vernamali Herman and the beautiful poem that she's written about her experience. This poem is called A Haunting on the Ward. Antiseptic Rips nose hangs heavy on the senses, bottles of it. Marker of passage, movement, boundary cling to me like smoke. Sterile corridors are littered with us behind curtains and charts, held down by bleached linen many hands have toiled out. The oppressed are a sick people, not in soul or in spirit, but in heart and lung, and mind and every other bit of body they've taken from us too. Here death is armed with pager and
jargon with a million different words that all end up meaning you ain't human enough for us. Outside nurse, become warden, become master, surveil and swarm beds, whisper secrets and write code. I think these wards are haunted, Mama, the way this place holds pain. There ain't much healing to be done where you can't get away from them ghosts.
That's all that we had for today, and we're online. If you haven't already asked your questions, we'll be online for another 10 minutes or so until the end of this session to answer those. So please feel free to pop some questions in there. Thank you very much for attending the QAI session on disability aware OPCAT monitoring, a COVID imperative. We hope you enjoy the rest of the conference and look forward to meeting up with you in person.